Good afternoon. I'm going to talk about the ICU management of raised intracranial pressure and head injuries, in particular the processes we follow in our neurocritical care unit at Neurocritical Hospital, University of Cape Town. So there are two effects of raised intracranial pressure. And this slide will demonstrate the first effect, which you have a mass lesion, such as the extradural shown at operation and at the CT scan, and the net result can be herniation. So you get midline shift, you get moving of the medial aspect of the temporal lobe, in compressing the interstitial space and compressing the brainstem, and this leads to the signs of herniation, which would be blown pupil, decreased level of consciousness, ipsilateral hemiparesis. Sorry, a contralateral normally hemiparesis, sometimes ipsilateral as a false localizing sign. And this can continuous herniation to for a Monroe herniation if the pressure is high enough, and then you get compression of the respiratory and cardiovascular centers in the brainstem and death. So the raised pressure can lead to herniation with its transdentorial or foramen magnum and death. The second effect, which is very commonly seen, in fact, seen in a large number of patients, but not always recognized, is cerebral ischemia. And it is thought that up to 50% of patients with raised intracranial pressure, mainly from head injuries, suffer from cerebral ischemia. And cerebral ischemia might result from hypoxia or from hypotension. So obviously the patients are hypoxic, they're not intubated, they're not breathing adequately and not getting enough oxygen into their system, they'll have hypoxic injury. So that is one of the reasons why severe head injury patients, for instance, will have to be intubated, normally ventilated, and that is to prevent hypoxia. The second important part is hypotension, and this was also explained why it's important to adequately resuscitate the patient so they are not hypotensive. A patient who post-injury is hypotensive and hypoxic will almost always suffer or frequently irreversible severe secondary injury to the brain. So what is the effect of hypotension? So everyone should know what the cerebral perfusion pressure, the CPP, that is the pressure that drives the blood flow through the brain. And we normally like to keep it over 60. It is variable between different people, but it is a difference between the mean arterial pressure and the intracranial pressure. So obviously, if the mean arterial pressure is low in a patient with raised intracranial pressure, the cerebral perfusion pressure is going to drop. And when it drops below a threshold of 50, you have almost invariably irreversible hypoxic brain injury. The picture on the right is of a completely hypoxic brain. Suffered irreversible hypoxic brain injury from hypotension. And you can see the grey-brown glass appearance. It's typical loss of grey-white matter differentiation. So cerebral ischemia is a vital part of your understanding of raised intracranial pressure and its management. And a lot of our management in the ICU is directed towards preventing cerebral ischemia and thus secondary head injury. So herniation versus hypoxia. It's not really herniation versus hypoxia. You can have both of them occurring in the same patient, but the management is not always entirely the same. It depends a little bit what your assessment is. Obviously, if you've got herniation from a large hematoma, you need to remove it. And if you've got hypoxia, you need to remove the causes of the hypoxia. You can have both of them occurring together as well. But these are the two main causes or results, from raised intracranial pressure, most commonly from trauma, but also from other causes. So what is our management at Neurocritical Hospital and the Neurocritical Care Unit of raised intracranial pressure? So first of all, how do we determine who has raised intracranial pressure? So there are two ways we do this in our unit. It's clinical. So the patient invariably will have a decreased level of consciousness. Yes, they might have papilledema, neck stiffness from tonsillar herniation, but the majority will have decreased level of consciousness. And remember, papilledema takes 24 to 48 hours to develop, so you won't see this necessarily in acute head injury, for example. So then the patient with a decreased level of consciousness will have a CT scan. Now, a CT scan will show us radiologically the patient has raised intracranial pressure. And the typical features are loss of the basal cisterns, effacement of the ventricles, diffuse cerebral swelling, loss of the cortical sulci arteries, and there might also be shift if there is a mass lesion such as a hematoma. So when we decide who we're going to put an intracranial pressure monitor in, it's invariably governed by the patient's decreased level of consciousness, normally in a head injury, because these are the patients who we put intracranial pressure monitors with findings on a CT scan that are in keeping with that. Having said that, if a patient has a coma scale after a head injury of less than 8, we will normally put an intracranial pressure monitor in anyway, even if it shows a diffuse axonal injury and with cerebral swelling not being a marked feature of that, because we know a large percentage of those patients will also have raised pressure. In addition, if the patient is a polytrauma patient and is going to require sedation over a prolonged period of time, you're not able to really measure the level of consciousness clinically. So we'll often put it, if there is a brain injury, we'll often put a intracranial pressure monitor in, even if it's not deemed to be that severe, so we can monitor the intracranial pressure. So this is just a picture showing the monitors that are used. You have a Camino monitor, which measures intracranial pressure. You can also have a Codman monitor, measures intracranial pressure. And you also have a Lycox, which measures oxygen tissue saturation. There's also a probe. They often put in a single bolt into the brain, with both going through the same bolt. And this can then be, using ICM Plus, can also be projected on a screen showing you what the intracranial pressure, etc., is, or you can just look at the numbers. I invariably just look at the numbers, and I can work out in my head largely what's going on, but it will help you with this diagrammatic representation. So what is the normal intracranial pressure? So intracranial pressure is normally 18, okay? And that's 18 millimeters of mercury, is measured by the intracranial pressure monitor, which is normally inserted into the substance of the brain. Partial tissue oxygen saturation pressure, is normally 16 to 20 millimeters of mercury, and that is measured by a Lycox monitor, which is the trade name. That is normally inserted with the intracranial pressure monitor through a single bolt system into the brain. The Lycox monitor has to be inserted into the white matter to get a reading that we can utilize. So the intracranial pressure is deemed to be elevated when it's above 18. We will monitor it into the early 20s and get more aggressive once it's above 25. The partial pressure of oxygen, if it's above 16, we will be happy with that. When there's hyperemia, it's normally above 30. Also, one needs to remember when you put a Lycox monitor, it takes a couple of hours to calibrate, so initially might be low and then we'll pick up. If it's put in the penumbra, it might, for a couple of days of a contusion, it might for a couple of days read low, and then as the penumbra recovers, it comes to normal. If you're going to measure intracranial pressure and partial pressure of oxygen, you invariably also have to measure the mean arterial pressure. In order to do that, you have to have an A line inserted, and we like to have the mean arterial pressure above 80, if we can, depending on the individual. And then obviously the cerebral perfusion pressure is calculated by the mean arterial pressure minus the intracranial pressure. And we like to maintain that above 60. However, there are variations with individuals. And for example, the cerebral perfusion pressure is 56, but the final common pathway, the partial oxygen, tissue oxygen pressure is normal. We will not try to push the CPP above 60 because you know the tissue oxygen is adequate. There's a lot of other ways people have monitored in the past. I find EEGs particularly useful, and ideally I'd like a continuous 4-lead anti-montage EEG, because that is very easy to read, and doctors and nurses can easily be trained to read it. And the main reason we like to have one is because if the patient intracranial pressure goes up, we can see if they're having a seizure or not. And if it's a seizure that's causing the intracranial pressure, then we obviously will treat that. Near-infrared spectroscopy has been used. It's not thought to be as accurate. Microdialysis is essentially experimental and does many more things than just measuring substrates in head injuries, but at the moment it's still experimental. There are other ways of measuring cerebral blood flow, and there's non-invasive intracranial pressure monitoring, none of which at this stage are as accurate as doing intracranial pressure monitoring. But oxygenation of the blood. Thank you.